Good morning to all of you. Topic of my presentation today is OCT analysis of RNFL and GCL thickness in non-glaucomatous optic neuropathies. Introduction. Non-glaucomatous optic neuropathy was defined as a clinical evidence of impaired optic nerve function in absence of field or discharges of glaucoma. Etiological groupings were determined as inflammatory, ischemic, toxic, nutritional optic neuropathy, and papilledema. A pale disease characteristic of a long-standing optic neuropathy. Optic atrophy is the end result of any disease that damages nerve anywhere between the retinal ganglion cells and the lateral geniculate body. The OCT is a non-invasive ocular imaging technique that uses low-coherence interferometry to generate in vivo high-resolution within 10 micron cross-sectional images of RNFL by measuring backscatter of infrared light. The measurement of RNFL can be an objective measurement of a nerve swelling or nerve atrophy by analyzing the ganglion cell complex. OCT can help to detect early axonal damage and may predict the visual outcome. My aim of study is to evaluate RNFL and GCL thickness in the patients with the non-glaucomatous optic neuropathy. My study design was cross-sectional observational study conducted in my department. Inclusion criteria was patient with optic neuropathies other than glaucoma, included age group 18 to 65 years. Exclusion criteria was anemia opacity, consecutive optic neuropathy, and excluding the age group less than 18 years and more than 65 years. Sample size was 51 eyes of 40 patients diagnosed as NGO and was compared with a healthy fellow eyes. Based on the fundus examination, NGO grouped as disc edema, dyspellar, and normal healthy. The study duration was 7 months. Here are the results. The demographic profile of the patients with the NGO showed male dominance with a mean age of 26 to 35 years in disc edema, 51 to 60 years in dyspellar. The mean average RNFL thickness in disc edema, dyspellar, and fellow eyes were 225, 67, and 91. Average RNFL thickness mean in disc edema, dyspellar, and fellow eyes was 67, 63, and 82. The statistical analysis was done by unpaired t-test. Here is the diagram. Here is the picture showing the right eye disc edema. Their overall thickness is increased and GCL is decreased. Here another scan of OCT of right dyspellar showing the both RNFL as well as GCL thinning. Discussion: the average RNFL thickness was raised in disc edema and decreased in dyspellar significantly. Henderson et al. Observed the raised RNFL thickness in acute optic neuritis and thinning of RNFL with a long duration. Between the RNFL and GCL thinning, toxic neuropathy, average RNFL thickness was significantly.
Doctor, you're not audible.
I'm audible or not?
Yes, doctor, but your sound is sounding very low.
I'm audible?
Yes.
The average GCL and IPL thickness was reduced in both disc edema and dyspellar significantly. As between the mean average GCC complex thickness was significantly reduced in NGO. Walterman et al. Reported that GCL and IPL thickness was reduced in optic neuritis associated with MS. Laminar and et al. Suggested overall thinning of GCC complex in disease. Conclusion: quantification of RNFL and GCL thickness. IOCT provides indirect measure of axonal and neuronal loss in anterior visual pathway. RNFL thickness varies depending on the type of neuropathy. GCC loss is the hallmark of optic neuropathy and should be monitored for early detection and prognosis in non-glaucomatous optic neuropathy patient. OCT can detect and subclinical axonal loss in patients with the normal visual acuity. Therefore, OCT may serve as a fast and economical test to aid in determining the non-glaucomatous optic neuropathy. Furthermore, OCT is useful in distinguishing macular disease from optic neuritis and in monitoring treatment. Multiple studies and clinical observations support the importance of OCT in diagnosis, treatment, and follow-up of optic neuropathy.